Good afternoon to one and all. Welcome to the third day of the AMRITA Online Medicine CME. Today we have 4 sessions, but it is with great regret that I would like to inform you that two of our speakers, Dr. Arun Divakar sir and Dr. Jyoti Srikanth ma'am, are currently COVID positive and are not well. Therefore, they will not be available for the live question and answer session at the end of their session. So if you have any doubts, you can type in the chat box, and the questions will be addressed at a later stage as a PDF that will be uploaded in the YouTube channel. So first, we have Dr. Arun Divakar sir. He is an associate professor at the AMRITA Institute of Medical Sciences in the Department of General Medicine. He is an excellent physician who is known for his commitment to the skill development of the postgraduate and undergraduate students that he is training. Welcome you, sir.
Good afternoon. So the topic which I'll be covering today is a rare complication which is seen in post-COVID patients. It is termed multi-system inflammatory syndrome in adults. So before I go into the topic, I would like to present a case which had come to the OPD. So this was a 23-year-old male with no comorbidities. Only thing that he was obese. He had presented with fever of 1 week duration and altered sensorium since 3 days and loose stools for the past 2 days. And initially he was admitted in a local hospital. In view of the GI symptoms, he was started on ceftriaxone after suspecting salmonella. And his salmonella IgM outside was positive. And despite treatment, he continued to have fever. And hence he was brought here to my OPD for further management. So this patient, when I saw him, he was delirious. He was in wheelchair bound. And when I checked his BP, it was around 80/50 millimeter of mercury. And his respiratory rate was around 40 per minute. So his saturation levels were 92% in room air. His RT-PCR was already done outside 24 hours back, which was negative. So since he was unstable, I had shifted him to the ER. And we did an ABG, which showed a severe metabolic acidosis, pH of 6.9 with a bicarb of 8.4. His counts were elevated to neutrophilic predominance. His C-reactive protein was around 184 with a procal more than 100. So we were suspecting it's a gram-negative sepsis, and his creat levels were around 6.7. So there was an acute kidney injury because his previous creatinine was normal when he got admitted in the local hospital. So, and he also had mild transaminitis. So subsequent blood tests, which we did in view of his hypertension, we sent the cardiac enzymes, and we found that the total CK levels were drastically elevated, around 4 to 6,000. And his troponins were also high, maybe due to renal dysfunction, we don't know. But then we suspected an underlying myocarditis. His D-dimer was around 9.5. So based on these lab parameters, it was a straightforward diagnosis. It is sepsis with multi-organ dysfunction syndrome with elevated procal, most likely a gram-negative sepsis. And because he was unstable, despite giving fluid boluses, he was shifted to the ICU. In view of low GCS, he was selectively intubated, and he was started on noradrenaline. And in view of the underlying sepsis, which was considered at that point of time, he was started on broad-spectrum antibiotics. He was initiated and on hemodialysis by the nephrologist. An echo done showed moderate to severe LV dysfunction. And in view of the elevated ferritin with such high counts, we suspected a secondary hemophagocytic syndrome, and steroids were also added. The salmonella IgM done here was weakly positive. The cultures were sent, which subsequently all the cultures were negative. In view of elevated CK levels, suspecting lepto, the leptospirosis was also negative. Urine routine showed 15 to 20 pus cells, but the cultures were all sterile. So is this a straightforward gram-negative sepsis? Can salmonella be causing all these problems? That was still questionable here. So what is happening here? Is it just salmonella causing this, or is there something else? What's the next question? So the relative of the patient, who was a doctor here, came forward and told that he had a COVID-like illness, which occurred around 3 weeks back, both for him and his father. But they never checked the RT-PCR, and they just took symptomatic treatment, and they were at home. And there is no history of any prior COVID vaccination. So, first is any post-COVID sequelae, and we send the COVID IgG levels, antibody levels, which is found to be positive, which shows that he has had a prior infection of COVID. So it was approximately around 3 weeks back. Now, before going into further details, so you know this is the most dreaded structure nowadays, right? So this is the SARS-CoV-2, and it's a strain of coronavirus that causes COVID-19. And prior to this, the strains, there have been other strains of coronaviruses that have caused 2 large-scale outbreaks in the past 2 decades. One was the SARS in 2002, other one was the MERS, the Middle East Respiratory Syndrome, in 2012. Both were these strains of coronavirus. And now in 2019, it's COVID-19, which is caused by the SARS-CoV-2. And if you look at the virus, you can see a series of protein spikes on its surface, which when viewed under a microscope, electron microscope, resembles a crown. So hence the name corona, which is Latin for crown. And you can see there are 4 structural proteins basically, which constitute the coronavirus. One is the S protein or the spike protein, the N protein or the nucleic capsid protein, the M protein or the membrane protein, and the E protein or the envelope protein. So these are the 4 different proteins which are seen here. So among this, the S protein is the protein which gives it the crown-like structure. And you can see in the S protein, there is a receptor binding domain which recognizes a specific receptor, which is the ACE2 receptor. I'll be coming into that in the subsequent slides. And you can see here, the S protein has got 2 functional subunits. One is the S1 and the S2. So the S1, it binds to the host cell receptor, and S2 mediates the fusion of the viral and cellular membranes. Okay. Now coming to the N protein, which is the nucleic capsid protein. This is seen within the virus. It is bound to the mRNA, which causes the virulence of this virus. The M protein or the membrane protein, which is the most abundant of the proteins, it defines the shape of the viral envelope. And the E protein, which is the smallest of the proteins, is the smallest of the proteins. So we'll be dealing with, and all these proteins, when formed together, gives it the definite shape of the SARS-CoV-2. Now coming to the different functions of the proteins, the spike protein or the S protein, it attaches to the host cell, especially it has an affinity for the ACE2 receptor. The N protein is bound to the single-stranded RNA. It inhibits the host cell's defense mechanisms. The M protein is most abundant. It defines the shape of the envelope. And the E protein, which is the smallest among these proteins, it's integral in the assembly and the release of virus from the host cells. So this gives it this definite structure, all these proteins. Now coming to the pathogenesis, as you can see here, the SARS-CoV-2 enters the host cell through interaction of its spike protein with the ACE2 receptors. Now coming to the AC2 receptors, they can be seen in the lung, in different organs. So where are these AC2 receptors predominantly situated? It can be seen in the lungs, the heart, the kidney, and the intestines. So causing this variety of complications. Now coming to the mechanisms for the pathogenesis, looks like a complicated slide. Okay, but as you can see, this COVID-19 causes both significant respiratory and extrapulmonary pathology. Because the SARS-CoV-2 spike protein has an affinity for angiotensin converting enzyme 2 receptors, which facilitate the entry of the virus into the cells, extrapulmonary manifestations are often noted in tissues that express angiotensin converting enzyme 2 receptors. The plausible mechanisms of injury include direct virus-mediated cytotoxic effects, dysregulation of the renin-angiotensin-aldosterone system resulting from downregulation of the angiotensin converting enzyme and causing viral-induced inflammation, which results in endothelial damage and thrombosis formation. And of course, the most predominant pathogenesis seen post-COVID syndrome, which results in a cytokine storm, is a dysregulation. It's a dysregulation of the immune response. And how does that occur? We'll go into these slides subsequently. So, as I mentioned here, direct virus-mediated cytotoxic effects, dysregulation of renin-angiotensin-aldosterone system leading on to endothelial damage and thrombus formation. And of course, the most important is the dysregulated immune response which occurs, which leads on to hyperinflammation. How does it cause? By inhibition of the interferons, depletion of the T lymphocytes, and production of the pro-inflammatory cytokines. So this hyperinflammatory syndrome of COVID-19 shares similarities with the cytokine release syndromes. So there are 3 progressive clinical phases in COVID-19. There's an early infective phase, where the clinical manifestations are driven actively by the replicating virus. A pulmonary phase, there is an overlap of viral replication effects and host inflammatory response, and of course the hyperinflammation phase, where the pathophysiological process is driven by the host inflammatory response. So this is the phase. The third phase is where majority of the complications occur. Now coming to post-acute 19, which will be, there'll be another talk by Dr. Deebu regarding post-COVID. So it's a syndrome characterized by persistence of clinical symptoms beyond 4 weeks from the onset of acute symptoms. So it can be classified based on a chronicity into subacute or persistent symptomatic COVID-19, whereas and chronic or post-COVID syndrome, where the symptoms are present beyond 12 weeks. Now coming to the multisystem inflammatory syndrome in adults. It is a post-infectious phase of COVID, which occurs approximately around 2 to 5 weeks after the COVID infection. It is driven by a dysregulated immune complex activation, causing direct endothelial damage and associated thromboinflammation. So again, the pathogenesis is similar. There's a dysregulation of renin-angiotensin-aldosterone system, leading on to thromboinflammation and endothelial damage. So the CDC case definition of multisystem inflammatory syndrome in adults. So any patient who's aged more than 21 years, that's the age cutoff for MISA. And there are certain clinical criteria and of course laboratory evidence. So clinical criteria can either be primary or secondary. So if you look at the case definition, a patient aged more than 21 years, hospitalized for more than 24 hours, meeting the following clinical and laboratory criteria. The patient would be having fever of more than 38 degrees centigrade. And coming to the primary clinical criteria, the patient should have severe cardiac illness like myocarditis, severe LV dysfunction, And another primary clinical criteria is a rash or a non-purulent conjunctivitis. Coming to the secondary clinical criteria, it can be a new onset neurological signs. They can have symptom signs of meningitis. They can have altered sensorium, encephalitis, and sometimes they can even present with GBS-like syndrome. Of course, shock or hypertension is another secondary clinical criteria, and presence of loose stools, diarrhea, and GI symptoms is another, and presence of thrombocytopenia. So these are the presence of any three of these. And of course, there should be a laboratory evidence, elevated levels of at least two of the following: the C-reactive protein, the ferritin, the IL-6, ESR, and the procalcitonin. And the procalcitonin can be elevated in multi-system inflammatory syndrome, which always confuses us. And of course, there should be a positive SARS-CoV-2 test for a recent infection. So you can see here the different organs which can involve and causing variety of symptoms. Encephalitis, it can cause uveitis, conjunctivitis. Okay, skin involvement can be there. There can be glomerulonephritis. And of course, myositis, rhabdomyolysis is another feature of MISC, which is not commonly seen in HLH. So another close mimic of multisystem inflammatory syndrome is HLH or macrophage activation syndrome, which is again one of the cytokine release syndromes. Now, of course, another comparison in multisystem inflammatory syndrome in children is similar to Kawasaki disease. I don't want to go into details of this. And there was a study which was conducted in US, which compared the various signs and symptoms which a patient presented in adults and children. And as you can see here, 84% of the patients presented with GI symptoms. They had vomiting and diarrhea. And 63% of these patients had hypotension. So the GI symptoms were relatively less common in children. This is a small trial, a study which is conducted in US. And you can see here the cardiac dysfunction was very prevalent in the adult population, around 55% of them. And myocarditis, pericardial effusions, all these things were common, and acute kidney injuries were very prevalent in the adult group. Myocarditis, you can see, is comparatively less in the pediatric population. So to summarize, the various differentials, as we had discussed earlier for MISA, is one is sepsis with multi-organ dysfunction syndrome, and of course hemophagocytic syndrome and macrophage activation syndrome. But in these two conditions, the ESR will be low. And of course, Kawasaki disease in case of children. So while I was preparing this topic, I was going through the literature, and I just found out that there's not much of literature regarding the multisystem inflammatory syndrome in adults. All the articles were predominantly on MISC. So it's a gray area. However, various studies are being undertaken in various centers all over the world. And one such study is capturing multi-organ related effects of COVID-19. This is being conducted in the United Kingdom, where 616 patients are taken, and they all have documented evidence of COVID-19 infection. And the study aims to investigate the long-term effects of COVID-19 on the lung, heart, brain, liver, kidney, using an advanced state-of-the-art MRI. Multi-organ MRI is used, and these organs will be screened at 3, 6, and 12 months. And this is another study published in JAMA on May 21, where they took more than 7,000 patients who had documented COVID-19 infection, and they shortlisted 15 patients who satisfied the criteria of multisystem inflammatory syndrome in adults. They found out that the patients with MISA were in the younger age group, and the number of organ systems involved was 4. And most of them recovered with antibiotics and immunosuppressive therapy. And this is a case series which was presented in the Morbidity and Mortality Weekly Report. This is done in United Kingdom and United States. Now coming to the treatment. So the treatment is either with IVIG, steroids, and of course there are adjunct therapies. So IVIG, it influences the number and function of the regulatory T cells and helps to control inflammation. So it's given as 2 grams per kilogram in a single infusion over 8 to 12 hours. In case of obese patients, the dose should be based on the ideal body weight. And of course, in patients with renal failure and LV dysfunction, this can be given in divided doses. And methylprednisolone is a preferred steroid, which is given at 2 milligram per kilogram per day in 2 divided doses. Once a patient improves clinically, it can be changed to oral prednisolone and tapered off over 3 to 4 weeks. There are certain adjunct therapies using the IL-1 inhibitors, anakinra, and IL-6, tocilizumab. But then these can be tried in cases which are refractory to IVIG and steroids. So the anakinra, the IL-1 inhibitor, is preferred over tocilizumab because of its safety profile and lesser myelosuppressive and hepatotoxic effects. All patients were treated with aspirin, which is in a low dose, and anticoagulants. So in the patient which presented to Amrita, he was started on IVIG and methylprednisolone as soon as we got the antibody positivity report. In view of his morbid obesity, it was given over 3 days. But once he was started on IVIG and steroids, he was weaned off inotropes, and the ventilatory parameters started improving. He was continued on rivaroxaban. A repeat echo showed an improvement in the LV systolic function. In view of his, he was shifted to a ward, but in the ward he had low volume pain for which a Doppler was done, which showed DVT. The anticoagulants were continued. And in view of persistent tachycardia, a CT pulmonary angiogram was also done, which showed a pulmonary thromboembolism in the posterior basal segment of the right descending pulmonary artery. But then it was continued on oral anticoagulants. One other thing which he had was he had persistently elevated cardiac enzymes, and he had new onset ECG changes. So can it be an underlying coronary artery disease? So he also underwent a coronary angiogram, which showed a normal coronaries. And subsequently underwent a cardiac MRI, which showed a non-ischemic myocardial scar. But the treatment was continued, and he significantly improved and was discharged with oral steroids and oral anticoagulants. Now send the follow-up. So what I want to highlight here is now when you teach the undergraduates or anyone regarding history taking, I think in this era, any patient presenting with PUO, a history of recent COVID infection or vaccination should be included in the case history, because many times I've seen patients even presenting with post-vaccination fever. And any patient with fever and multi-organ dysfunction syndrome with sterile cultures, the possibility of multisystem inflammatory syndrome should be considered. So the take-home message, the multisystem MISA is an underdiagnosed complication of COVID-19 infection. In patients presenting with atypical features or late presentation with high inflammatory markers, cardiac enzymes, with or without renal and liver failure, should undergo antibody testing to aid the diagnosis. Early diagnosis and prompt treatment with agents like steroids, IVIG, and supportive care helps in saving lives. The cause of MISA can be complicated with thromboembolic events, autonomic dysfunction, which has to be diagnosed and treated on time. So with this, I would like to end my presentation. And you can see here the virus is constantly changing. And now, recently, there's a new entity which is coming soon. Neo-COVID. I think we'll have to wait and watch for this. And before I end my presentation, I would like to thank my HOD, Dr. M.J. Kipula, for giving me this opportunity to present in the CME. And of course, the organizing secretary, Dr. Subhash. And I would like to extend sincere thanks to my postgraduates, especially Dr. Bhagya Lakshmi, for helping me prepare this presentation. Thank you.
Thank you very much, sir, for that informative session.